Hello, everyone. I'm Richard Conway from Dublin, Ireland, and this is QD Clinics for RheumNow. The title of today's QD Clinic is Stick or Twist. So this is the case of a 65-year-old lady. She has seropositive rheumatoid arthritis, strongly positive for both rheumatoid factor and CCP, and she's been attending my clinic for the last 25 years with her rheumatoid. She's currently on methotrexate 20 milligrams weekly and adalimumab 40 milligrams every 2 weeks. And she's been on these medications for 10 years or more. And for that time, since she started adalimumab, her disease has been under good control. She comes in, she's no complaints ever, no problems with the medication, no flares of the rheumatoid. Her CDI generally runs around 0 or 1. So she's happy out. And she's had a CT scan done. It's a CT, thorax, abdomen, and pelvis, and it's been done somewhere else for the investigation of a little bit of weight loss. Maybe a scan that didn't need to be done at all, but it has been done. And it has come back largely normal. But the physician who's ordered a scan for her has contacted me in a panic because the scan has been reported as showing interstitial lung disease. So the question here is, what do we do with this? We've got a lady who is well, she's asymptomatic. Her rheumatoid is under very good control on her existing medications of methotrexate and adalimumab, but she has this finding of interstitial lung disease. And we all know that rheumatoid arthritis, interstitial lung disease, at least traditionally, has a very, very poor prognosis, associated with high mortality. So it is something that makes us sit up and pay attention. But maybe now that we're doing more scans on asymptomatic people, we could be identifying interstitial lung disease that is not associated with such a severe prognosis. So the first thing here we should do, again, double check the lady has no symptoms. She doesn't. Have a listen to her chest. She's a few little crackles in the bases of her lungs, but nothing too dramatic. And then have a look at this CT scan that's been done. So this CT, it does have interstitial lung disease. It has basal, subpleural, predominant fibrotic change, consistent with UIP or consistent with rheumatoid arthritis interstitial lung disease. But it doesn't have very much. It's only a little bit that's there. It's not extending throughout the lower lobes or throughout the whole lung field. It's only a little bit at the basis. So then we look back, see if this lady has had any scans previously that we could compare it to. She hasn't. She hasn't had any pulmonary function tests. So we get some of those done to assess how her pulmonary function is. Her FVC comes in at 105%. Her DLCO is 65%, so a little bit reduced. But it's always important to look at other reasons this might be. So we asked this lady, well, did you ever smoke? And she did. She used to smoke quite a lot. She's an ex-smoker, stopped 20 years ago, but was smoking a pack of cigarettes a day before that. So then the question becomes, we have a lady who is essentially asymptomatic. She possibly has normal pulmonary function given her background history of smoking, or we have another explanation for that. And should we change anything? Should we change methotrexate? Should we change adalimumab to some other agents? So the methotrexate for me is the one that always comes up. Our pulmonologists get very excited by methotrexate and its effect on the lungs. We know that methotrexate can cause an acute pneumonitis. It very rarely causes this. It's about 0.3% of people on methotrexate. But it does happen. That's not what this is. This isn't a pneumonitis. This is interstitial lung disease with a fibrotic pattern. So that's not what we're dealing with here. And we know the best evidence available to us from the ERAS and ERAN studies, from other studies like Philip Jewett has done, has shown us that methotrexate is not associated with an increased risk of rheumatoid arthritis interstitial lung disease. And if anything, it seems to be protective both for the development and the progression of this condition. So I'm very comfortable saying we should definitely stay on methotrexate in this case. And the adalimumab then, so adalimumab and TNF inhibitors have been associated with a suggestion that they might be more associated with the progression of and the development of rheumatoid interstitial lung disease compared to some of our other agents. The evidence base for that is relatively weak, and it's hard to know if there is an association there, why it happens. And the important thing is that there is one thing that we do know quite convincingly seems to be associated with RA-ILD development and progression, and that's disease activity. And we have this lady who has absolute pristine disease activity control for 10 years or more. And to me, there seems to be no justification to switch her biologic to an agent that there may be some very weak evidence might be better for interstitial lung disease than the TNF inhibitor when we have somebody under good disease control and we're going to risk worsening her disease control to switch to an agent that there might be a small benefit for. And the other thing we don't know in this case is we don't know what way this is going. We have no past data there. So I would say that it's very, very reasonable to leave this lady on her current treatment, do another set of pulmonary function tests whenever you think is appropriate, 3 months, 6 months, a year. I'd probably leave it a year in a case like this, but something around that time scale, and see how things are progressing. We have time here, and we don't need to overreact to this incidental finding on CT scan. So that's today's case from QD Clinics. It is when you shouldn't change treatment in RA-ILD. So tune into RheumNow for more from QD Clinics.